Our next speaker is Fred Wigley. He's director at the Johns Hopkins Scleroderma Center and professor at Johns Hopkins. He's also associate director of the Division of Rheumatology. He's received his MD at the University of Florida, his internship and residency, and his fellowship at Johns Hopkins. He's gotten the Rheumatology Masters Award, and he's won a Rare Champion of Hope Award, and of course published extensively in scleroderma, and he's going to talk about scleroderma, evidence of a vascular disease.
I'm going to change gears a little bit and talk about the vascular component of this most interesting and complex rheumatic disease. We tend to think about it as just a fibrotic disease. We know it's an autoimmune disease, but I'm going to make an argument today that the vascular process is fundamental to the underlying pathogenesis of this disorder. See, so I put, this one. These are my disclosures. The outline of the lecture is I'll first review with you some of the clinical features that you're all familiar with systemic sclerosis. Then we'll talk about the pathological features of the vascular disease, and we'll spend some time looking at the mechanisms of what we think are causing the pathogenesis so that we can perhaps rationally think about intervention that may be helpful. And then finally, the consequences of the vascular disease in scleroderma. As you all know, Raynaud's phenomena is common in almost every patient that has scleroderma. This picture that you see here, a patient of mine sent me and said, you know, you really don't have a good picture of Raynaud's, and this is one. And so we know that scleroderma has vascular reactivity. We also are very familiar with the nail fold capillary changes that occur. So there are these capillary vessel changes and vessel loss that are part of this disease process. And then there are microvascular events that occur that are so problematic in our patients, these painful ischemic digital ulcers. But in addition, we need to appreciate that there's macrovascular disease that can occur, and particularly those patients that have long-lasting disease. And there's a subset of patients that are at increased risk for these kinds of catastrophic larger vessel events. This sophisticated cartoon that I drew outlines in a dark blue the areas where the thermoregulatory vessels that are so important to maintain our core temperature are distributed. And interestingly, these are the ones that are twitchy to the temperature and are accountable for the onset of Raynaud's. And if you look at that distribution, it's exactly in the same distribution as the worst fibrotic skin disease, suggesting that the vascular disease and the fibrotic process are interrelated very tightly. And I'll make an argument for how that might happen. But we recognize that Raynaud's is not the only vascular phenomena. Renal crisis occurs. If you have an RNA polymerase antibody, it's up to 25% of patients are at risk. Pulmonary hypertension occurs in around 12% of patients, particularly those with limited disease. Cardiac disease is all too common. In fact, some studies suggest if you look carefully, it's seen in up to 75% of our patients, likely due to microvascular disease and subsequent fibrosis. The gastrointestinal dysfunction is thought to be vascular in origin and neuropathic as a consequence, and we know that they can get small telangiectatic lesions that bleed in many of our patients. In men, it's very common to have impotence due to vascular disease. The diagnosis of scleroderma can be helped by the simple test at the bedside of looking at the nail fold capillary. And here we see the nail fold. We look right here. I usually use immersion oil, then take my thaumascope and put it on diopter 40 and take a close look at the nail fold, which is easily seen. Here's the nail. Here you can see these capillaries. They become layout right next to the nail at this site. It was in 1926 when Dr. Brown first recognized that in patients with scleroderma, by the way, I might have changed a couple of the slides in your handout.